First of all, I have to apologize for my bad English. I'm a psychiatrist. I worked for 35 years in public health services in Milano, Italy. And now, since 2-3 years, I'm retired. And I'm interested in this topic and in natural resources promotion in Italy. The hidden resources that will be useful for the patients. I will speak, yes, about our program that is the first program in Italy called Semola and is a program starting from adult psychiatric services. In Italy we have no such programs, only 3 teams are involved in company. But they are not linked, and the 2 other programs are not working with the patient, just on a research level. Italy participated to the Contatto research group and the European project Camilla is an epidemiological project. Only adult services are involved with, no children or educational. There is no data collecting and no national specific policy. Also because the family is perceived in Italy as a sacred environment, not to enter in. In Italy you can really speak for forgotten children for good reasons. On the contrary, since 2 years we have a blog by a user, a young daughter, that was very angry against the services. They don't speak, they don't talk her about the mother illness. And this is a very, very good initiative. We are connected with her, and we are trying to do our website now. In Italy, the adult services approaches are characterized, but I think that all in the world is that focusing on the patient and his symptoms or skills like occupational, domestic, but not to the parenting skills. And they feel, psychiatrists fear of risking the relationship with the patient if they talk about. There is a tendency to regard this problem not as a competence of adult service, but of children ones. But children services don't they do. They do that. Formally correct is a cooperation among services, but with strong boundaries. The Semola program is a selective. It means that we address just to children, to families coming from adult psychiatric patient services, 6 to 14 years old. We are working with 2 mental health adult services, 2 community mental health services centers, with the model Let's Talk and Family Talk intervention, in partnership with a family association, and financed by the municipality of Milano, and linked with this blog. The goal are to open a dialogue on parenting with these adult parents, the patients, the services, to sensitively assess the family situation, sensitively not to hard assessment, to facilitate the sharing of issues, provide answer to the child, provide peer group support. We have experience with this kind of support, peer help and natural helpers, to provide additional service for children like social support or school support. This is the flow chart. After the interview by the nurse asks some information about the patient, and also if the patient has children or not. If the patient has children, in the first interview with the psychiatrist, there is also a co-worker, is a nurse or a social worker, with the psychiatrist in order to assess all the situation of the patient, not just the symptoms and the question of the patient to the psychiatrist, just to assess all, as a whole person. After this first interview, we offer the possibility to have one session less talk with a psychologist of our program and a co-worker of the service. Co-worker is a social worker or nurses. After let's talk, no other intervention, just feedback to the service, family talk intervention, 6-8 sessions, Verti groups, I don't know if you know what is a Verti group, but it's a group with parents and in parallel with parents and with children, or natural social network activation. What is the problem? That we had a lot of first interviews, a lot of people with children, and 63 patients with children 14 years old. The psychiatrist referred 40, and we is not too much, but is also not satisfying for us. 34 less talk and just 7 family talk intervention. And we put some questions. It's a satisfied journey with all people involved, but why this selection? Which are the factors involved? What happens? What happens at the different level? At the professional level, I think that is more easy for a psychiatrist to refer if the professional is feeling as a parent or no parent, is a problem with his parenting attitude situation. Or if the psychiatrist has a political sensitivity or is a family therapist, but also there is a problem with a chief of a service, there is a family therapist who told us, no, this is a problem of family therapy. It's not a problem that could be approached just by self-education, by talking. We have to do a family therapy. Or the confidence with the patient is also a topic interesting, because if the confidence is very high, that is a long-term patient with confidence between him and the therapist, could be okay. Also, if at the first interview, because this is a neutral setting, I have not to looking for your parenting abilities because I think that you are bad parent, just as a routine procedure. In the middle, we have problem because the psychiatrist wait to send people, wait to put himself this problem. At the patient level, we saw that the patients are satisfied because they feel to receive attention as a new person, they discover new parental abilities, they got a new way to look at the children's problem, and they express other extra clinical needs. That means social needs, for example. That is not appropriate demand. Who are the parents who receive the Semola? The parents who have awareness, the parents who have problems with the partner, who want to discuss with the psychiatrist or psychologist the problem with the partner. No severe disease, but the severe disease are 60–70% of the population of our the mental health department in Italy. We have a community mental health center and no specific programs on schizophrenia, depression, bipolar, and so on. When they are not satisfied with the answer, they do more, and the other reasons are met. Mothers are more prone. I don't know if there is a global situation that mothers are more prone to discuss about their parenting abilities than fathers, and satisfaction with the professional, and concern. But concern about children is not very common, and is not that doesn't come alone. it's a question that has to be let to arise from the client. Why after Let's Talk session so few family talk intervention? Because we have no, because between couples there could be there is no problems and they would not to talk about. Situation is okay. Good identification with children needs. I don't need to go deeply. No severe disease, more verbal. People are prone to receive family talk intervention. And children know that parents came to Let's Talk. When children know that parents receive Let's Talk, they parents are more prone to come. At the service level, we saw that we were working with two adult mental services. With one, the procedure is mandatory, with the other not mandatory. And where it is mandatory is better running the program. Where the company is appreciated, when the chief the services were orientated, and where a neutral location out of the services, and when the community mental services need more information on the patient. The provider is also important, where the interested to company is much more with the provider well-funded, interested in the integration between social and services, positive attitude, and need to stimulate the quality improvement. But anyway, we saw many resistances, cultural, political, juridic, disciplinary, lack of resources, service organization, service network, single service, it's not my competence, I'm not trained, I'm not the time for the patient more, or personal emotion, this is very important. A theoretical problem is that we approach to the just mental illness per children or to all the children, because all the many typologies of children have common needs, and maybe that the risk is if we address to a specific target population, we risk to stigmatize, to create a typology. But when we address to all children, we have a problem for evaluation. This is a theoretical problem for COPMI, ethical, scientific, economic, medicine, psychology, education, culture, where we are. Final considerations are that we have to improve the traditional workforce attitudes, try to address to basic risk factor like expulsion, or give clinical intervention with the risk of transform a social problem for difficulties for families into a medical one. Consider common problem or specific diagnosis-based, stress the ethical sense or scientific sense, and which kind of evaluation. Which are the wishes for COPMI in Italy? That we have to offer COPMI as a routine procedures. We have to participate, we would like to participate in a cross-sectional study, but with a strong defined model in order to compare different programs, support a new partnership between users, but we have a good level of this topic, create a common database to collect and compare the data, and finally to take into account the cultural differences. Which are the next action in Italy? That we will have a national conference in 2015. You are invited, but the conference is in Italian language. We are doing a website with this daughter, I told you, and we are trying to extend to educational services like schools and social and family service, because children's services are not too interested to do that. They are not a preventive approach. Thank you for your attention, and if you want to contact us, these are our.
So there's a few minutes for questions.
If I can understand the question.
So if
There are some. If you want.
So is there any questions for Edoardo?
You understand instead of the English.
Question?
Thank you for presenting all of this. I'm just wondering if you could comment on stigma and mental illness in the Italian context.
You see, we have a very good reform, psychiatric reform. We closed all the hospitals. We have no problems now with families because 20 years ago families are angry against the closure of the hospital. But we are not the ability to give mental illness an objective definition like other illness, somatic illness, for example, because we are considered maybe too much the subjectivity, the relationships, and so on. And this means that you have difficulties to lead a campaign against stigma. Because a campaign against stigma starts from defining what is illness, that illness is depression, bipolar, and so on. We have a resistance to do that. This is the first problem. And the second problem is that the family structure is very hard in Italy, and it tends to not to show problems inside, and this is a problem also for stigma, shame of that. The third problem is an economical one, that we have no financial support for anti-stigma campaigns. There are just some examples, some experiences, but not a program, nationwide or regional-wide program.
Good to know. Thank you.
So any
When did Italy decide to close its institutions and why?
Why? Why they don't work? Why mental hospitals don't work at all? Because they treat all the patients in the same way, because they have a long-term hospitalization, because it's impossible to treat people outside his environment. It's an artificial situation. And because they cost more than communities.
What had to happen for Italy? Because in Mexico we're trying to close institutions, but it's
It's a long journey.
did you find cases? Was it like
We started by a law in 1978, but we had to wait for 20 years when a financial law stated that they have to be closed because they cost too much. Is the both a scientific not too much, ethical and political first, second economical, and third scientific. But now there is no struggle from family, from professional, in order to open new residential facilities. We have residential facilities, of course, more sheltered or less sheltered, but we have, of course. But we have no mental hospital.
At the risk of asking something too political, was anyone of you study Roma or from other ethnic backgrounds? And do you know how much they need services?
How much?
How much they need services, access to services?
How much they need?
Whether or not they need access to services as a minority population in Italy.
I didn't understand the question, sorry. How many people are ill, or how many people?
No, I was wondering if anyone in your study was Roma.
No, in Milano.
Okay.
This is in Milano, just in
So
Milano.
it's just people from Milan.
Just people from two community mental center, one with 80,000 people,
Okay.
one other with 70,000 people in the catchment area, one with 1,400 people treated, the other with 1,100, and with 60% schizophrenic patients, and around 400 first interview each year. And there is a selection, and just 63 were in the, with children between 6 and 14 years.
But did you mean the Roma people, not people from Rome?
Yeah.
No.
She doesn't mean from Rome, she means the, I don't know,
Romani?
gypsy is the,
Ah,
yes,
sorry,
yes.
sorry, wrong.
Yeah.
Gypsy people. Gypsy people like, sorry.
It's okay.
Gypsy people like migrant people, they use service just in the acute situation. They don't come to, they come in very few cases because they are put away their community, they become homeless, but a few cases. We are not too many gypsies in Milano, but they are, I think, 8,000 in 1,300,000 people. But they come just in acute wards in the hospital, in the acute units in the ward. And I just saw 10 in the last 10 years, if you want. But they are also, the family in the gypsy groups is particular. Or all included, or well, like Chinese in some way, in Milano. I didn't understand at all.
So we can move on to the next presentation, is that? Okay. So